Glenn.
There, I started the recording. This is our monthly informatics rehab call. And this is March 16, 2023, just so everybody has that if you're listening in. We're talking about the proposals for CSM. And then, and Sam, in a minute, you get to introduce Madeline and her presentation and anything else as well. But two other things that I have, I mentioned CSM. Great presentations this year, a lot of fun. We can talk about that and debrief maybe towards the end or whenever, but I want to make sure we have time for Madeline to go through her information. And then again, the reminder for the proposals this year. The second thing next month, CT Lynn, who is the Chief Medical Information Officer at it's UC Health, I believe, right, Sam?
That's correct. Yeah.
Okay. And CT, I have met him a couple times through Chime, had the opportunity to hear him present a couple of times. Just a really good speaker, good person. He's a great CIO for their group and such. He is going to be leading us through an aspect of storytelling, and I forget the exact title, Sam. I may defer to you in a moment, but we will be doing some stuff. Basically, it's around storytelling related to data, and we'll be doing some breakout groups and such with that as well during that time. So, Sam, I'm going to turn it over to you. How's that?
Yeah, thank you, Bob. Yeah, there's some exciting avenues for next few months. But today I have the privilege of introducing and hearing from Madeline Ratoza. She's one of our core members, and she is currently a clinical educator, instructor for University of St. Augustine for Health Sciences. And she's also a former graduate of UCSF and SFSU. Her specialties are clinical education and population health. And in our conversations, there's been a lot of topics and kind of things that are related at the population health level. So, and she is currently in a PhD program, and her current work, her project that she's going to be sharing today is called Modeling Rehabilitation Provider Shortage in Texas with Population Data. So we're excited. We want to know what you're doing. Perhaps we could give you some feedback and some probing with some questions and going from there. So thank you, Madeline, again, for sharing your time with us.
Awesome. Thank you, Sam, for the introduction. I just wanted to get kind of an idea as to how many people here have worked with population data before. Has anyone? Sam? Yep. And
Stephen done some work in that area.
Awesome. Perfect.
Brian Bossier, just a little bit.
Awesome. And then where would we rate our sort of knowledge of social determinants of health, structural determinants of health?
Trying to put them into the EMR or
just in general, I guess.
Yeah.
Yeah. 0 to 10 or what?
Yeah, just how would you rate sort of what you're coming into this with, so I know sort of where to speak to?
Enough to be dangerous.
Okay. All right. Well, I'm going to share my screen. I have a presentation. I'm probably not going to go through like line by line of the slides. I'm just going to kind of give you a bit of an overview. I'll try to make your pictures bigger here so I can see your faces. There we go. Okay. So let me make this.
Yep.
All right. Okay, so this is sort of the title of my project. This is a working situation. I'm in a PhD program, so this is my dissertation proposal. And if you've ever done a PhD or done anything by committee, you know that it's not a quick process. So that's where we are. A bit about how I got to this topic. Practiced for about 6 years. I started a PhD program at Texas Women's about 4 years ago. At the same time, I started teaching at the University of St. Augustine. And I am in a PhD program in physical therapy, but they have allowed me to take my electives throughout the university. So I've taken half of them in the nursing department and half of them in the MS in informatics program. So I don't have degrees in those things, but that's where I get the lens from social determinants of health and informatics. So it's sort of the intersection of those disciplines, even though it's a rehab project. So I'll talk to you a bit about the purpose, the research questions, and my methods, which are, again, I haven't done it. So some of those may change as I get deeper into the data. The basic overview of this project is that social determinants of health have major impacts on our health outcomes. One of those determinants is access. Other disciplines have ways of tracking and assessing access. While we know there is a significant need for rehabilitation worldwide, we don't have a lot of information about how our populations are accessing therapy. And so the purpose of this is really to start to model healthcare provider shortage and rehab and what that looks like. So for those of you that are not sure of your knowledge as relates to social determinants of health, we'll give a brief background of what they are. So they're basically the non-medical factors that impact our health outcomes. We're really starting to talk to them in terms of social and structural determinants of health. But while they encompass a number of things, this is one of the models from Healthy People 2030. You can see other models that represent social determinants of health, including, the Kaiser Family Foundation has one that's a little more in depth and includes food, which I think is a major one, not really specified in this model. But I do like this model because it really targets access, which I think is a really important aspect of how we're getting to the people that need our care. So my project is focusing on this specific aspect of all of the social determinants of health. What is access? It's essentially the timely use of services, and it includes coverage, services, timeliness, and workforce. And you'll see as we get into the data we have, we're really focusing on this, this workforce piece when it comes to therapy. And of course, insurance and the amount of time it would take to get to that service is also important. This project is not covering insurance per se, but knowing that that's a piece of the model as well. So there's a number of ways we can look at access from sort of a theoretical model. So these are different ways of sort of addressing how health systems and how people are accessing services within healthcare systems. One that's being used recently is the Levesque conceptual framework. What's interesting about this framework, and although it was introduced really recently and is being used in a lot of research currently, it doesn't actually include workforce very specifically in its model. So I'm going back and sort of using an older model, which is Panchansky and Thomas's, and really focusing on the availability of resources as well as the accessibility to geographic locations. Because the resources include personnel, which if you're receiving rehab services, is fairly important that you have someone that can provide that service. And so this is, if I'm looking at availability and accessibility of service, this really includes potential access. So those of you that work in healthcare systems, you're often using data of all the people that have accessed your services already. So this is really taking into account the population of people, whether or not they're accessing the system and whether or not they have the potential to access that system based on geography and personnel. So what do we know about access through other disciplines? Primary care has a number of different ways to kind of look at access. They have medically underserved areas and medically underserved populations. And they also utilize the healthcare professional shortage areas. And these are basically calculations in which they're tabulating the likelihood of that particular area. It can be a different geographic location, like either census tract or a larger area. But it is basically providing an indicator for whether or not there are enough providers given the population. And within this calculation, they are taking into account a indicator of need, which for for primary care is this infant mortality rate. And so we have these models, and they can calculate the ratios and therefore come up with these maps and show the areas of the country or the state where there are enough providers and where there are not enough providers. And so they have these for primary care, mental health, and dental health, and they're starting to, they've received comments back for making designations related to maternity care target areas as well. So that's not initiated quite yet, but that's in progress. So they only have these 4 sort of definitions of how they are defining areas of need. What do we currently know about rehabilitation and access? We don't know a ton, so I'm going to kind of breeze through this as kind of like background lit review. We know that Rehabilitation 2030 is saying that there's a profound unmet need. There are a couple priority areas, 2 of which really relate to the purpose of this project, which are we need to progressively achieve equitable access, and we need information relevant to rehab services. We have had some research within specific areas, looking at underserved adults, looking at populations of people experiencing homelessness, all of which are basically showing that one of the reasons we don't have providers, we don't have medically underserved adults are not receiving services, or because the providers don't exist in those areas. And that we have a profound unmet need for certain populations, specifically those experiencing homelessness. Then we have sort of the large reviews looking at social determinants of health and physical therapy use, and found that there are a number of factors that indicate whether or not people access services. The biggest ones are urban environment and access to transportation. And noting that these studies are really looking at health center data, so people that are already accessing the system, rather than, again, that potential access. There are some studies that have looked at utilizing geospatial analysis for access to rehab, and this is sort of where we get closer to what this project is intending to do. There's not a ton of this research done in rehab specifically. And it's not often done in the United States. But what has been done shows that we see a pretty big mismatch between the geographic locations of outpatient clinics and the areas in which disparities exist. So in a study done in the Denver area, they mapped out outpatient clinics and looked at the social factors of the people that lived in those areas, and found that areas with greater disparity had far fewer outpatient clinics. And then in a pilot study done in Australia, they were looking at the concentration of those living with disability, and found that rehab services were in areas where there was a lower concentration of people living with disability. And then in a study looking at certified hand therapists, they found that the certified hand therapists were located in densely populated areas as well, with low poverty rates. So we're seeing a kind of mismatch of where our services are being provided to the people that should, in theory, need those services. So the purpose of this is we don't have a way of measuring or tracking access in physical therapy in a standardized way. We have a couple of these different studies that are showing some disparities, but we don't have sort of a national way of tracking this. This is important because there are some financial incentives for programs that have health professional shortage areas, such as if you are a primary care physician and you go to open a practice in a medically underserved area, you have tax breaks associated with Medicare, and you also can receive or have the potential to receive loan repayment programs for working in those areas. We don't have these in therapy, really in any of the allied health professionals. And having this ability would allow us to show that, where we had need and give us support to be part of these programs. And this really tracks well with a couple of the 2 main advocacy issues supported by the APTA at this time, which are the health information technology advocacy, as well as this workforce advocacy to include PTs in state and federal programs. And if you know my other area of research, it really aligns directly with student loan issues and financial literacy. And so this is really where they come together with this advocacy standpoint, trying to be included in these programs. So I'm planning to do this to model access and rehab using the population data we have available. Are there any questions before I kind of go into the methods?
This is Bob. I have a question, and I also put it in the chat. When I look at this data related to SDOH, and I think about past in the EHR right now, like I know you can pull data out of ICD-10 coding, but that's not used very often, at least in my experience, those codes. We can pull certain data from demographics, but how else can we pull the social determinants of health data to even be looking at the access? Is it going outside and just looking at public data, or?
Yeah, so this
Thoughts?
project is using only public data, not EHR data. We'll get into where I'm pulling the data from, but it's really census tract government related data. And the purpose is I'm not looking at who's accessing a healthcare system, because who's accessing a healthcare system is leaving out those that are not accessing that healthcare system. So
Gotcha.
it's really looking at in the areas where they exist, what are those demographics looking like?
Interesting. I'm just thinking if we map those two on top of one another at some point, it'll be cool as well. Thanks.
Yeah, Bob, I have actually, to your question, there are Z codes that are in ICD-10, but it has been, I don't think they're used very often, or at least
Oh,
from my experience. And that's one of the learning factors. I don't know what the stats across the nation, but in our local region, it's not used very much. So
CMS has reported it's like less than 11% of the time that they think they should be used, that they are used.
yeah.
All right, so I'll kind of go forward. So the methods are basically to use secondary analysis of the following publicly available data sources. And I'll get into a bit of the error associated with some of this data and the imperfections with it, but these are sort of where the data is going to be pulled from. There's the Texas Behavioral Risk Factor Surveillance System. There's the Texas Physical Therapy Examiners List, which includes all licensed PTs and OTs. I've operationally defined rehab access as PTs and OTs for this project. So it will include both of those providers, and then ACS data through the census. And then I'm going to be looking at outpatient rehab providers, and that will be a compilation of lists that exist essentially. So this is sort of the more detail that we probably need to get into today, but essentially going to be looking at geographic access to rehabilitation using some geospatial analysis, and then modeling the access. I'm trying to build out a model that is in somewhat representative of what that HPSA is in other disciplines. And these are sort of my questions, looking at what the geographic variability of the provider ratio is, how that compares to driving distance, and the concentration of people with disability in Texas. And then using all the data that's been organized for the studies in question 1, I'm going to basically calculate an HPSA score for rehab per geographic region within Texas, and then compare that to how that looks to primary care provider ratio. And this is basically showing what that is going to look like. Again, it's probably more detailed than we need to go into today, but essentially have the PT provider ratio from the data. I'm going to put that in this component of the HPSA model. the driving distances will be calculated. That will go over here. The percent that below the poverty level is through census data. And then the biggest question we had in coming up with this project is what the indicator of need is. So for primary care, it's infant mortality rate. For dentistry, it's fluoridization in the water. And for mental health care, it's a number of different factors, including alcohol rate, elderly rate, teenage rate, smoking rate, things like that, that go into what that indicator of need is. And so I've been reading through, government files of how they're determining what those indicators of need are. And it's sort of random. And it's also sort of just related to whatever data exists. So they're coming up with maternity care target areas, and they basically say, we should include maternity care providers that are primary care physicians that are working in rural counties that also provide maternity care when they need to. And they say, that's great, but that data doesn't exist, so we won't include it. So it's essentially something that relates to the cause that you have data available for. And so I'm basically pulling the indicators of need from the behavioral risk factor surveillance study and using those to sort of, they are difficulty walking, difficulty dressing, and so I think I have it on another slide. We'll get to that. Some of the data realities are that our data includes business address and home address, but some of that data is incomplete. So we're kind of looking at it from, these are where the therapists are located based on their home address, knowing that's not exactly a perfect data source because they may work outside of their census tract. So I'm sort of going to compare where they live to where they work and see what amount of data that amount of error that exists within that. And so this kind of goes into a little bit of detail about why I'm making that decision. When you look at the data that does geographic analysis, they're basically determining what data sources they're using, what distance they're using based on how providers operate. And so with physical therapy, we sort of have a really
And Madeline, it seems to be going in and out a little bit. So while we're waiting for Madeline's audio to recover, we will, oh, Madeline, you're back with us? We're checking. Nope, she still froze up a little bit. Part of this came up out of a discussion related to social determinants of health, which is, I think we all know it's a hot topic out there right now. And this is part of what she's doing her thesis on. And so it looks like you're back now, Madeline, yes?
I think so. Is it better?
Okay.
Yeah.
Perfect. Go ahead.
Sometimes it switches to my short range internet. So we went back. Okay. So yes, so I am basically going to use the home address of the PTOT, knowing that that's maybe not a perfect, they may not all be working exactly in that location, but they will be working close enough to that location that they would be able to provide services, because a lot of us practicing are having multiple jobs. We may have PRN jobs, we may have full-time jobs in a clinic and additional jobs. So being able to track us down to a 1 FTE, as some other providers do, is simply not feasible in rehab. So that's kind of how we're looking at it. And this is basically this is taken from other studies, but this is the type of reporting and analysis that I would come out with. So looking at sort of how the map would, of course, be Texas rather than the entire United States, and smaller regional levels, and looking at how the distribution of providers are. So if you look at how the providers exist within primary care, generally located in large urban areas, generally not located in the rural areas, but you can also see with looking at a smaller demographic of census tracts, you can see that they're actually not distributed evenly across major metropolitan areas. So that's sort of what we would be looking at. And then the next step would be to use how the area compares to the clinics located there. So this is, you take the providers that exist within the region, and then you take the driving distance from the centroid of that census tract to all the outpatient clinics that you can then locate. And the map on the left is taken from a really interesting study looking at primary care in Philadelphia, and they're basically dividing those by quintiles of access. And if you know anything about Philadelphia's demographics, you already know what that story is telling you about the regions in which have access to primary care and those that do not. And then the map in the middle is a really interesting study done on anesthesiologists and looking at the availability of anesthesiologists around hospital regions. And you can see those, light yellow, gray regions in the middle really don't have access to anesthesiology providers at all for pediatrics. So that's the type of things that I would plan to do with this. And then this study I talked about before, it's the Australian study looking at concentration of rehab services and those with disability. So they basically found that those, the little dots are the areas where the clinics are located, and then the areas where those people that are living with disability are actually the darker orange regions around it. So we're seeing a big mismatch there as well. So this is the type of thing that I would then look for, sort of the hotspots within Texas and how that compared to the demographics in that region. And then essentially it all goes into this model. The indicators of need are taken from the behavioral risk factor surveillance. And then I would include a combination of this data that exists in there within the census tract and put that in as the indicator of need. And then the final question is how that ratio compares to our primary care HPSA ratio. And the concept there is we've been arguing and advocating for being part of these programs for a number of years. So saying like we should just be included in HPSAs for primary cares. And if they're similar, right, if one can predict the other, then we don't really need to track rehab across the board. We can just be included in those other service lines because we tend to follow where the primary care access is anyway. But if they're different, that might tell us that we need to actually be tracking this more closely for rehab. And that's about it. That's the plan.
Madeline, I'm going to jump in on that last one, and great job. Thank you. The question, so you said we've been advocating for a long time to be part of the loan forgiveness, right? Do you know what the current status, do you or anybody know the current status? I know APTA has been talking about it a lot. Are physical therapists included in one of the bills that's out there?
I do not believe so. So we're currently not in, like if you go work in underserved areas, we're not included in those loan forgiveness programs. And I, of course, was like telling my dentist about this because, your dentist like, how's your dissertation going? I'm like, oh, this is what I'm working on. He's like, well, you can't, like that those programs don't work to begin with. And so that was kind of like, this was like a couple weeks ago. And I was like, that's news to me. Like I never knew that like maybe they don't even work in the first place. So that's something to consider, but they do in theory still exist.
I know that it was one of the advocacy pushes APTA was working on. And so I was just curious along those lines. Other questions? So Sarah, you made a comment here in the chat. Do you want to add into that further? If you can unmute and just add.
Exactly. If I can unmute, I don't know if I can find, there's my video. Okay. So when I first moved to Nevada over a decade ago, I started this conversation with our licensing board here in part for the underserved, because I had started my business and could not find therapists. Didn't even know for myself how to find a job. The infrastructure in my area is just so vastly different than anywhere else I've been in the country. So when I started the conversation with the board, they said, basically, we have enough PTs. So we're not included in any shortage areas. And I was like, that's funny, because I can't find anyone, nor can I figure out how I find a job myself if I wanted to apply for something. So they did it by pure number and breakdown. Like, they literally said, we have this many PTs for this much population, bottom line. So it wasn't broken down by region. Like, we have a ton of rural areas that have no providers like many states do. It wasn't broken down like that. But the biggest things were, we have a large population of providers here who don't actively work. So I would get licensure lists and I would start contacting people, and the answers I got is, I'm not working, I'm not working, I'm not working, I'm not working. And that is not taken into account. So Madeline, when you mentioned about some people use their home address as their business address, that was one of the thoughts that came to mind with why that might be that way in the data. And then, of course, like myself, I work from home, so my business address is, but besides that, it's just not tracked in any way that's meaningful. So I'm in pediatrics. And so even if we did have those breakdowns, even if it was more centralized by region of the state, Nevada is a huge state square footage wise, there still aren't enough pediatric PTs. So even if there's enough, if it's true that there are enough PTs per population, there aren't enough to do pediatrics. There aren't enough to do complicated neurological cases, things of that nature. So I don't know how meaningful, or maybe that's just next step in the process, there's a base model made, then to extrapolate further into that. I just, it drives me crazy to have,
Hey, Sarah?
I understand why we have to go through those steps,
No,
but
Sarah.
if we jump
Sarah?
right to like the heart of it.
So Sarah, I'm gonna just interrupt here just for a moment here, just so that Madeline has a chance to address. Okay. So Madeline, how does that play into the data that you are looking at collecting? Is that just one of those pieces you're describing that's going to be an error in the data?
Yeah, so this is I think that's a really good point, and I think that there is there is that potential that the meaning is fuzzy, but then you get into the situation where I think it's not done because we're like, it's not great, right? It's not going to be perfect. And then we are kind of talking about this the other week, the chicken and the egg. Like, you don't track data, you don't track the things unless you think they're meaningful. So there are some states that track this stuff better than Texas. Those states don't quite have the health disparities that we see in places like Texas, because they also do other things better. But so some of that stuff is tracked, but oftentimes we have to show the problems in order to be able to track them better. So it's a bit of, we either don't do it because it's like not perfect, or we start doing it and show what we have. And that is a way to say, okay, this is first of all how you do it. This is how you would do it. And we need to then advocate for our states to get this information better. Or we talk about this in education, we need to track our graduates better so that we have standard national provider numbers and we're tracking where they go. We don't currently track attrition in our profession at all. So then we start to track that. But unless we start looking at this, then we won't know how bad it is or what it even looks like, or have a stake in starting to do better at it.
You know, Madeline, I think I 100% agree with you. I think we need to do a better job across not just post-professional level, but we got to weave it back to postgraduate, like alumni collection of what our graduates are doing. I think those are all perfectly well said. I'm wondering, from Sarah's point, you know, how do you find, or how do you locate those PTs who aren't really working? And I'm wondering if there's any avenue to look at claims data or billing data, which kind of falls into, okay, there's Medicare, but what about commercial payers? There's market scan, but you have to pay for those. It gets a little tricky, but if you bill for it, and you know where you billed, like that's a pretty legitimate validity there. Like, is there any opportunities to somehow include that avenue?
Potentially, but it wouldn't, we wouldn't include those that are doing cash pay or anything like that as well. So I'm not sure how complete it would be. I mean, I have the email list. So one thing to do is to survey and get sort of a subset and get the percentage of those licensures that are working and get sort of an idea about how many are potentially out of the market. And then even if you say, okay, some are out of the market, but you still see this huge divergence in where they're located, even if some subset of population aren't actually working, we maintain licensure every 2 years. So they're at least going through the process of keeping their license for some reason. So technically their availability would be that they're at least able to, right? So
Yeah, it's going to be a tricky slope. I mean, to know if what kind of roles they're actually actively playing, are they, just because you got your license active, it doesn't mean they're actually treating patients either. I think there's a few of us here even have their license, but we may not directly see patients. So that's always going to be hard. I agree. I think we need to really focus on how do you do that longitudinally, starting from, I think, from the education side, to make sure that we can collect that. Any other questions?
So I have a follow-up, and Rick, this relates to something you were chatting here about. Some states might have an inactive status, so maybe your license remains active, but there's a recognition that you're not actively employed or such. Other states don't have that, but I'm wondering if that could be teased out further. And maybe that goes to what Sarah was asking, that at least at a state level, we are encouraging our boards to look at it that way. Maybe. Rick, is that what you were thinking there? Sorry.
Yeah, I mean, I think that could be helpful to kind of carve out some of those clinicians who may not be actively practicing in the state. And I have a lot of state licenses. So I think to Madeline, and Madeline, by the way, great work, very, very interesting. And kind of to your point, some of the states do a really good job of asking exactly where you're working and how many hours a week you're working there. So I think some states do a pretty decent job. So they have the data within their system to know how many people who have a license within the state are actually practicing in the state, and ultimately where they're practicing.
So you're looking particularly at Texas in part because you're there. And so I don't know what it's like in Texas. It's kind of neat, though, to even think about this idea of where the shortages are and what the causes of those. And as Sarah brings up some of these others, and Rick, as you're talking multiple state licensures, how do we truly know what's going on? Your study is pretty cool. I like it.
we'll see what it becomes. It's not done yet.
Yeah, so going to this whole topic of social determinants of health, and Seth, I'm going to call you out a little bit if it's okay, because I did put a comment to you in the chat as well. And we talked a little bit at CSM, and I do want to have just a few minutes. We can talk some about CSM, but I'm curious, in your organization, are you guys pulling data related to social determinants of health? And can you look at that related to rehab? And maybe just share, sorry.
That's an interesting, it's an interesting point that you bring up. And I think this is fascinating. Listening to your presentation so far has been very, very interesting. We don't Right now, from our end, we don't. Do the insurance companies pull it? Potentially, they're pulling it because they have to make sure that their networks. Actually, I say that now. I think about it a little bit more. The projects that I'm involved with don't. There are some other ones. When it comes to determining a health plan's network, they are going to geomap the area a little bit better. I think of one of the states that we were working on, and they actually did have a geomap looking to ensure that there were enough providers within that healthcare network to cover all the patients they would have. Many plans are looking at something similar to that. They don't want to have a pocket. When you start going to add a network, then the costs go through the roof. So that would be something that many would look for.
Cool. And just so everybody knows, Seth and I, again, we talked briefly at CSM at our panel, and he is looking at this from the payer perspective. He's a physical therapist that's working for a payer. So that's why I was really curious about, you know, do they have different data or looking at it in a different way? Thanks, Seth.
Not a problem.
Other questions, comments related to either social determinants of health or to therapist availability in different locations?
Bob, I actually have a point going back to what Sam was talking about. Sam, you were asking about using the claims data to determine whether a provider was practicing or not. I'll be honest with you, we work with a bunch of different health plans. It's not that clean. You're going to find it's listed under a facility, it's listed under a provider, it's listed under another provider's name. It's just not that clean.
Yeah, there's a reason why they call it, like, we have a billing department or just like a whole division. It's like a black box. We don't know how it
It's completely different per plan. Like even within the plan, though, it's not clean. Sorry.
Yeah, no, I mean, I think it's still better than nothing. I completely, you know, like EHR data, is it ever going to be perfect? No, but would you rather go back to paper? Yeah.
So one question that comes up, and we talked, or I think you mentioned it a little bit, is the NPIs of therapists. So an NPI does carry across from state to state, et cetera. But right now, just like you're describing, Seth, we can bill underneath a provider's NPI. But and the other piece is that physical therapist assistants don't have to get an NPI. But each of us, if each of us did have to get an NPI number, would that allow, for instance, Madeline and Sam, you talked about the ability to track students and look at outcomes at some point and see, you know, if your students were doing what you were teaching them or something. I'm just wondering if we all had NPI numbers, would it make a difference or not?
NPIs are the most inaccurate number you will find. When it comes to us trying to put providers in our system, NPIs are always wrong. I get calls about NPIs day and night. Our company actually will tend to go more towards tax ID. It's easier to group providers under the tax ID for the facility than it is to have them under their individual NPI.
But the tax ID wouldn't be helpful at this point because it's
Correct.
too general, too broad. So what do you recommend would be like alternative? Is it the matter of the intent was there to use the NPI, but we're just using it wrong, or a lack of good pathway to like longitudinally track it? You know what I mean? It's the process that's the problem rather than the actual data element.
So much data that we all are collecting, and it's coming from so many different sources, and it's just you have to get people to update information. So NPI being one of those pieces that they would need to input, they're not great about it. You're getting facilities NPIs covering for a provider's NPI. It's just there's too many numbers out there, and that's parts where it gets really messy at this time.
Interesting. Other questions related to this, and you can ask Madeline stuff at any point in time too, just so you know. I want to touch base. changing just a little bit to CSM. I know several of us were out at Combined Sections meeting. I mentioned earlier proposals, the deadline has been extended to March 31, so please take a look at that and get your proposals in. But also just wanted to ask, what did you see or learn at CSM? What comments to share with others? What do you wish that you could see related to informatics, to data, to health IT maybe? And for those who know me, if I don't hear comments, I do call out people, and it's not to call out people, it's just so that you have a chance to say something. So I'll start out calling out people. So there's a couple people whose I have not heard voices from. Andrew Dietz, and I'll go to you and then go to AJ, just so that you guys have a chance to say something. Andrew?
Hi, Bob and everybody. Thanks for having me today. I joined, I was not able to attend CSM this year. I am a co-worker with Seth Cohen, who spoke just a minute ago, and we both have great affinity and interest in these topics. I'm also a PT. A little bit of background on myself. I've worked with Seth now for going on 3 years. I am a licensed clinician, although I am one of those that is currently not treating patients. Prior to my working with Seth, I have my own outpatient clinic with a couple locations in South Florida, which I had subsequently sold. So now I'm on the other end of things, working in the managed care sector with Seth. So thanks for having me.
Not a problem. And I'm really happy you guys are here. And Seth, again, thanks for coming up and talking to me. I think that if we take the time to learn even more from that payer side, it's going to help all of us out with providing care and with doing it in an even better way going forward. AJ, I'll go to you next, and then go to Mark Besh afterwards. AJ?
Yeah. Hello, everyone. This is my first time attending this meeting, and I wasn't able to attend the CSM. And I did not even know that there was something going on with the PT informatics side, like the physical therapists are working towards informatics and rehabilitation informatics. And when I saw Sam's picture with the CSM and everything on LinkedIn, I was like, yay, I found somebody who's working towards it. So I'm just a newbie. I'm a physical therapist, been working for the last 12 years in skilled nursing. I'm a program manager right now, but my interest in informatics has been, I've had a long interest. I started working towards it. I have a certificate program in healthcare informatics from UT Health Science Center, Houston. I'm in Houston, so that's how I started working towards it. But I don't have any practical experience working with any of the data. I'm just trying to know how physical therapists are working. Physical therapists are working towards informatics. So that's the reason I'm attending this meeting, to know how things work and how physical therapists are getting into informatics. So I hope I can learn more. So that's the reason why I'm here.
Very cool. And we're happy you're here too. And it was kind of, when you said Houston, ties right in what Madeline was describing here, huh? All about Texas.
Yeah. Yeah. I was just thinking about the NPI number, but Sam brought it up. I was thinking about the NPI number to physical therapists in active or inactive status. I was just thinking about it, but I think Seth gave the answer that NPI number is not a valid thing towards finding whether PTs, that would be a good identifier for the data set. So
Thank you.
Hey,
And
Bob.
Mark, I'm going to go to Matt first because he has his hand raised. Oh,
Sorry.
somebody said something. Go ahead,
Sorry.
Seth, real quick.
So Andrew and I were talking in the background, and we actually thought of an idea that may help a little bit, Madeline. It's EHRs. Everybody's got to sign in. And so trying to figure out which clinicians are signing in, of course, that's not going to help with anybody that's still using paper. But if there was a way through the EHRs to figure out who has a login, it could at least give you a little bit of an idea of who's practicing and in what areas. And
So I
I
would say,
like that, but how, I mean, my students on rotation, like if I have 30 students on rotation, they're probably using 20 different EHR systems. So like it would be logins for 20 different companies
right.
in one state.
I
Yeah,
was
that
just
idea.
thinking post-acute care, we do the same thing as anybody who's doing PRN in different organizations. You have a login with each of them. Go ahead, Sam.
No, I'm just thinking logically. That technically it's doable. It's just how are you going to go through the loops of pulling that information? Because you still need the provider ID, the record itself. So legally, it still goes through the funnels the same way. Yeah, but I like that idea. It's totally doable. Technically, it's doable. Yeah.
So I'm going to
Matt,
go to, yeah, Matt has his hand up and then go to Mark. Go ahead, Matt. Sorry, Sam, that's what you were saying.
yeah.
Yeah, I just had a couple of questions from a payer perspective. I put one in the chat, which is the NPI issue. Is that true for all providers? Or are you just seeing that more with physical therapists or the rehab? I'm just wondering if the physician community has the same quote unquote issue with NPI numbers.
Across the board. Doesn't matter. The programs that Andrew and I work on, we deal with physical therapists, occupational therapists, speech therapists, chiropractors, surgeons, pain management. It's all the same.
Yeah, and the reason why I'm asking that is because there's a lot of requirements coming through the federal government with health information exchange and requirements that are being bestowed on them and moving to data standards. Are you guys involved in any of that? Are you aware of some of those different things? And do you see some insights from there that can be gained and shared, especially as it relates to the rehab community?
There are people on our team that are involved in that.
Yeah, because that would be helpful to have, their perspective, because that's kind of the world that I'm knee deep in. It's from those data standards and hearing their comments as it relates, because I think that feedback is not as prevalent in the data standards community. And if that's reality, it needs to be spoken up a little bit louder. So I would encourage you to encourage them to have a louder voice.
Thank you, Matt.
Thanks, Matt. Additional, okay, Mark, go ahead, and then we'll go to Ching next.
Yeah, thanks, Bob. I didn't attend CSM either, so unfortunately can't comment on that. But specific to the topic of the day, two thoughts that I have, somewhat unrelated. But one is, I wonder whether APTA could provide some level of detail about therapist employments and settings. I think in our renewals, they ask us how many hours do you work and et cetera. So they might be able to comment. I realize that that's only a subset of all of the licensed therapists, but it would be a subset. And I don't know if you could draw conclusions from that. So that's one thought. The second thought that strikes me as I've listened to the discussion is a use case in terms of if we had the ability to measure workforce and from an advocacy perspective with CMS, we talk a lot about rural and underserved areas. It's a challenge staffing, but we don't have any data to back that up. So data would be very powerful from an advocacy perspective, I think. And I'm thinking, obviously, we all know about the reduction on assistant provided services, but that's what strikes me. So those are my two thoughts of the day, if you will.
Pretty good thoughts too. Ching, we'll go to you next, and then I am looking at the time and want to pause then and go to Sam afterwards. Ching?
Sorry, is it for my reflection on CSF?
Reflection on CSM or today, the
Okay.
topic.
My reflection on CSM, actually, I went to a couple of presentations and like a bigger institution about their application, implementation of kind of like CPGs embedded in their EHR system. My question, like after that was great. I went to Steven's presentation was great. I asked questions. I feel like it's great to have those done in a bigger institution, larger healthcare system. However, how about the smaller outpatient clinics? Like, is there a way, like I was thinking, like we can create even like a spreadsheet along with the CPGs. So if you use the CPGs, this is the tracker, like a tracker for your outcome, patient outcome. If you agree to use it, and we can pull some de-identified data to use it. So it's kind of like it's mutual benefit. You use it to improve the patient outcome, but share some of the identified data with the whole association, and we can look at smaller private outpatient clinics, the patient outcome by implementation of these CPGs. In addition to like a bigger healthcare system, because I hear a lot of smaller owners saying, I just don't have those time to create it. I don't know how. I don't know how to implement it.
And that was related to a proposal topic that we tossed out. And I think, Sam, go ahead. Maybe you can mention it.
So I think that's a really good point, Jing. I think so we're proposing a topic around data use around. It could be broader than CPG, but we want to get like variety, diverse stakeholders, including those private and of 1 or 2 or 3, and how are they using data? So I don't have a good answer for you. But I think I'm pretty sure their clinics are using some level of data, maybe beyond spreadsheets. I don't know, maybe they're using spreadsheets, but hold that thought, because we are trying to really coral up the right stakeholder for the session, so that we want to hear from other representatives, especially around the private practice. Yeah.
So we are right near the top of the hour. I do want to mention next month we are going to do for an hour and a half. And that is in part because CT, what we were talking about earlier, CT Lin is the Chief Medical Information Officer at, I think, UC Health in Denver. He basically started doing open notes, open documentation approximately 10 years ago. Really a fascinating person to hear some of his stories and etc. He's going to talk with us about how we do storytelling around the data that we have to actually bring additional meaning to that data. And he wants us to do some breakout groups and actually have the opportunity back and forth with some stuff related to storytelling with our data. So just so you have a sense as to what's coming there. And Sam, I'm done with comments. I'm going to let you wrap us up.
I just want to thank you, Madeline. I think this is an awesome project that you're working on. Thank you so much for presenting today's session. We're gonna probably come back to you again and over again with this population health topic. But thank you all for today's session. And then if you have any specific informatics topics that you're really passionate about, you want us to like help you or give you feedback or anything like that, please reach out to this group. We're more than happy to collaborate and support. So thank you all.
Now I might have a question.
Sure, I can stay on for I have a hard stop at 10:05.
Okay, no worries. I can ask. It's just the question I asked you earlier about like if the DHI